Okay, good morning, everybody, and I'm just going to present our experience with all of these drugs. We have been using them since they have come into the market. So it's not all about injections, and it's simple and complicated. I will skip most of those slides. Retinal vein occlusion does impair quality of life, so that's why it's important to treat. And what we are treating, there are three main complications of retinal vein occlusion. One is macular edema, which is the most common cause of visual impairment, macular ischemia and retinal ischemia. What now has come through is like you can have new elsewhere, like in one of our patients, you can see a good NV in these cases. So you will just do a sector PRP. I will try to skip those. Non-ischemic CRVO sometimes can resolve on its own. This was one of our patients who came with macular edema. We advised him to have Ozurdex at that time, but for some reason he could not have it. If you see, there was macular edema over there, but 1 year later on, he resolved on its own without any treatment. So some of the non-ischemics would resolve on their own. But if you see a patient like this was a patient who came to us. He had been back to India, and he was advised abstain. There is no capillary circulation at all in this case, and so giving anything would not benefit this patient. This is a gone. What you need to do is good PRP in these cases. And then, as we have said, like we've got people in UK who go for exotic vacations to Thailand, and then they come with vein occlusion sometimes. And then if you see, some of them are like this one with syphilis, was treated with just with antibiotics. In BRVO, there is a lot of patients who will resolve on their own. From our side, investigation we do is just medical history, blood pressure, serum glucose, full blood count, and ESR. And if any of these are abnormal, then only we go for further testing. What it has been shown to test for homocysteine and all of those has not been beneficial for every patient. So it's only for very selective patients you should go for these. These are the main reasons for treatment of retinal vein occlusion. You want to aim for stable vision, improvement in retinal anatomy, and avoid sequelae. And there are various studies which have shown I just want to point out that there was an IVTA study, and it showed IV intravitreal triamcinolone does not work. Dexamethasone, as you know, is a 700 milligram implant, and that's the Geneva study which showed it. And what the main thing is, if you see, the peak effect of the Ozurdex comes at 2 months, and the effect remains up to 4 to 6 months. The effect lasts less in CRVO patients. So in CRVO, you see the effect weighing on around 3 to 4 months time. I'll show you some cases, but in BRVO, it can last up to 6 months. That's what it shows. And then you give another injection, then it goes back again. The side effect, there's a cataract progression around 29.8% in phakic eyes. IOP is a problem. In only 3.2% of the patient had IOP of 35. But declined significantly by 3 months, and was 0% by 6. So I don't think that's a big problem, and I've not had a case where we had to go for the surgery after Ozurdex implant, and most of them are managed with that. So this is one of our patients. So that's the baseline OCT, macular edema. 1 week post-op, as you see, the macular edema is starting to resolve. 2 months, it's completely stable. As you can see, the retinal anatomy looks quite good. But at 4 months, the fluid has started to come back again. Now, anti-VEGF for CRVO, as I said, like the VEGF is more in CRVO, almost 69 times higher. So that's why you need to treat heavy and treat early. Ranibizumab was the first drug which was used, and I think they have already gone through the cruise trial. But I just wanted to point out in the cruise trial was that the original arm was where they treated early, and then they continued with the treatment. The second black arm is the one where they did not treat for the first 6 months and then started to treat with PRN and ranibizumab. But if you see, there was always a gap between those two groups. So if you suspect retinal vein occlusion, you need to treat early and you need to treat heavy, because even you might get anatomical resolution, you will not get visual resolution in all these cases. So you need to let the patient know. Like if a lot of patients say, should we wait? Say, if you wait, okay, your anatomy might look better, but your vision might not be as good as otherwise. And that's where patients get more than 5 letters. And then there was the Horizon study, which was a arm for that. And then the Retain study, which again showed similar things. Lucentis for CRVO, this is a patient, one of our patients for retinal vein occlusion. That's the fluorescein angiogram you can see with macular edema. Post-Lucentis injections, it resolved. Then we have been using ILIA, that aflibercept from the Copernicus trial, which showed, and it was a similar type of study where there was a sham and a normal injection room. And then if you see the Copernicus results, there was more than 15 letter gain in the ILIA group. So there was 56.1% patient improved with aflibercept. So aflibercept, because it's a longer acting, slightly longer acting, and it works on 2 or 3 types of VEGF, it has got slightly better results. And if you see, the mean change of visual acuity were almost 18 ETDRS letters than the others. And this is one of our patients of ILIA with CRVO. So this is the baseline color pattern, the picture, and OCT. And you can see there's a massive macular edema. This is 2 days after, so that's what we were saying. So that is 2 days after injection. If you see, the macular edema is almost completely gone with the ILIA injections. This is another of the ILIA patients. If you see, there's gross macular edema. And if you see, that's the baseline OCT. After 4 injections, the retina is completely normal. But between 5th and 6th injection, the fluid came back again. We gave them further injections, and after 7 injections, the patient has not required further injections. So that's the main point. You need to treat early, you need to treat heavy. So give at least 4 or 5 injections to start with. If you just treat by 1 or 2 injections, it's not going to do any good to the patients. And that's our patient start. If you see, the visual acuity improved and it remained consistent, while the CRT dropped and it remained dropped all around. Then came the Galileo trial, which again showed for BRVO similar results, where there was more than 18 letters of improvement in these cases with ILIA. So what are we treating? So now what we do, laser is only now restricted to of less than 3 months duration and visual acuity less than 6/12, and there is no macular hemorrhage. If there is macular hemorrhage, you can't do laser, so it's no use giving. So it's a very small selected population where laser would work. While anti-VEGF, as I said, the Bravo study showed that the results were good, and then the Horizon and the Retail. And then we have got ILIA, there's the Vibrant study, and the 52-week results came back this month only in the Ophthalmology Journal, and it shows a mean gain of 17 letters for the ILIA patients.
Sir, can we wrap up? Finish it up. Yeah,
baseline,
thanks,
then 4 injections, 5 injections, and if you see, that's what happens in any of those patients. So what we do is basically Ozurdex we use in retinal vein occlusion, especially patients who are pseudophakic and who do not have glaucoma. While anti-VEGF we give heavy in initial phase, and if there's neovascularization, then we need to do laser. And the choice of agent depends on different criteria, as we have said. Retreatment is important, and the Ozurdex, like I said, would need treatment. This is important. Why? When we do, should we stop treatment? So give 3 injections of anti-VEGF. See if there is no visual gain of more than 5 letters, and there is no CRT thickness decrease. Then either you change to a different drug, that is Ozurdex, or change to ILIA. But if after another 3 injections there is still no response, then you stop the treatment. That patient is not going to respond, so it's no use giving any further injections. Switching agents, there is no RCT, but it's worthwhile because the way Ozurdex and anti-VEGF work are slightly different. So some of the patients we have who did not respond with anti-VEGF responded with Ozurdex, and then vice versa also, where some of the patients who were on Ozurdex did not respond well, and we switched to the anti-VEGF. Thank you.